transplantation in lymphoma in the context of new drugs.
So, good afternoon, ladies and gentlemen. First of all, I thank, of course, the local organizers, and I guess also a little bit Dika for the invitation to join us here. I have never been in Lithuania, and I hope that at least I will have a short glimpse into the city and find out what's special about this country. This is not the first slide, so can I do with this? Yeah. Okay, so thank you very much. I feel a little bit underprivileged here because, you know, you heard 6 talks about one disease, and I have now to talk, you know, the only one being talking about something like 100 diseases. And I think one lesson, you know, you have to learn in the beginning when you want to do transplants in lymphoma, don't believe that all the lymphomas are created equal. You know, the lymphomas are very different, and even if you are doing autologous or allogeneic or both kinds of transplants on them, they behave very, very different, and therefore, you know, you have to know a little bit about lymphomas and about the differences. Of course, I will not be able, you know, although I have 40 minutes, I will not be able to talk about all the different subtypes of lymphoma. So what I did is, you know, I chose a few examples where the principles of treating lymphoma with transplantation, you know, you are able to see them, and I'm certainly, you know, not able in every single lymphoma sub-entity to give you all the different studies and give you all the details which you might want to know. There is certainly, you know, time for a little bit of discussion. I think the first message here is autologous transplantation and transplantation in general for lymphoma is still alive and well, like it is in the myelomas, although we have also in lymphoma a lot of new drugs, and I will show you some examples how you would combine transplantation with some of the new drugs during the talk. So I think there is a fair number of transplants for lymphoma here, and I think lymphoma still is head-to-head with myeloma one of the most frequent indications for transplantation. Discussing the different entities, I would like to start with Hodgkin lymphoma, and here you see another EBMT slide, and you see that, of course, autologous transplantation, like in all the lymphoma subtypes, is much, much more frequently done than allogeneic transplantation, but as in other diseases, I think the number of allogeneic transplants is rising. In Hodgkin's disease, I think all of you know that the first-line results, if you're giving ABVD or if you give the B-Corp regimen, which is very, very popular in Germany, the results are very good. And therefore, of course, nobody is talking adding or giving autologous or allogeneic transplantation as part of first-line therapy. If patients with Hodgkin's disease, even in 2016, if they relapse, then you are going to have a problem. It's not this easy to deal with these patients. And that was the reason why, you know, many years ago, it was published in 2002, we did that study, which was called the HDR1 study. And the idea of the study was that we wanted to do upfront randomization of patients with different kinds of relapse, and then we gave them a very aggressive salvage regimen, and we compared it to the same regimen, 2 courses, and the CR and PR patients, so only the chemosensitive patients, they would then move on to an autotransplantation after beam high-dose chemotherapy. And this here is one of the results. This is from an update we did in 2005. And here you are looking again at the chemosensitive patients. And here in red, these are the patients who had the auto transplant. And these in blue here are the patients who had only the DEXA beam regimen. And as you see, even with longer follow-up, there was a significant difference in favor of the autologous transplant. There was no difference in overall survival like it had been shown in the original publication. There have been a lot of attempts, to improve the results, giving more salvage therapy before chemotherapy, and it really didn't work very well. So now the question here is, and I think that is one of the key issues here for the talk, you have a lot of new molecules, antibodies and molecules. What can you use to improve the situation? And let's say, you can look down the list here. I think, for instance, this here is a bispecific antibody. There is a study being done in the German study group, no results available. Lenalidomide, I think you have heard a lot about it in myeloma. There is also some people looking at it in diffuse large B-cell lymphoma. In T-cell lymphoma, I don't think that in Hodgkin's disease it's one of the drugs which really will make it. I will show you one slide on one of the mTOR inhibitors. This year, I think, is the past. I think, not only in the German Hodgkin study group, but in other study groups, there have been attempts to use anti-CD20 antibodies, nothing coming out of it. HDAC inhibitors, effective sometimes, not very much. And I think you can, skip all the other for the discussion here, except, of course, for the anti-PD-1 or anti-PD-1 ligand antibodies. There is very promising early results, but I think I would stress early results. It's very few patients having been treated. It seems to be quite active. The questions how long the remissions will be, how deep the remissions will be, all of that we have to look at it. We don't know. So this is just, one example what's being done. This is, I would say, the standard now, at least in Germany. So you give a salvage regimen. We are in the Hodgkin's disease patients mostly given DHAP, and the ones who are then becoming PET negative, hopefully, or achieving at least a partial remission, they would move on to beam high-dose therapy and autologous transplantation. And giving everolimus on top of that, of course, carries the hope that there will be more patients being taken to transplant. And I think, this is something, which whatever the lymphoma is, whatever the situation is, that is what is the key issue when you talk about relapsed refractory lymphoma. You have a patient who has growing lumps in the neck or wherever it is, and what you want is to do a transplant, because transplants, even in 2016, is a measure to put the patient in long-term remission. Some patients after allogeneic transplantation may be cured. The question is, how can you get as many patients as possible to transplantation? And that, is the remaining topic in Hodgkin, in B-cell lymphoma, in T-cell lymphoma. You want to increase the number of patients making it to transplantation. There is no result of this particular study here. I show you some other examples later in other diseases where possibly adding new drugs to chemotherapy, you can improve the situation for the patients. Talking about Hodgkin's disease, I think the only drugs for the moment being here to stay is brentuximab vedotin, and it is the checkpoint inhibitors, the PD-1 or PD-1 ligand antibodies. I'm certainly not explaining to you what all of it is. I have no time to do that, so we just have a look what's happening. Brentuximab vedotin, of course, is quite attractive in patients with Hodgkin's disease because the Hodgkin's lymphoma cells, they are all strongly CD30 positive, so you can use that drug. And one approach is, of course, giving brentuximab vedotin as a salvage therapy prior to autologous transplantation, so no chemotherapy at all, just brentuximab. In brackets, it's also chemotherapy, but it is targeted therapy. And then you are looking, what's happening. And I think, again, I'm not going to take you through all the details. What was seen in that study published recently in Biology of Blood and Marrow Transplantation was that you saw a fair overall response rate. 35% of the patients achieved a CR, and it seemed to be that it was not this toxic as you were giving, for instance, DHAP. So I think this is certainly a promising concept. For those who were not really satisfied with it, Then, of course, what you can do is you can give brentuximab vedotin and add other drugs which the patient has not been seeing. For instance, bendamustine. Again, in that small study, very good overall response rates and also good safety profiles. This is something, which was published recently in the Lancet Oncology by Craig Moskowitz. This, is another study. It's tackling the same problem. You give brentuximab vedotin, and then, you end up with augmented ICE, so a salvage regimen which we have been using over decades already. And again, the message here is you hopefully bring more patients through transplantation, and thereby you improve the situation for the relapsed refractory population at large. And there's, another study. You can combine it also with DHIP. I think I have just shown you some examples. In Hodgkin's disease, this is the topic. If you want to use new drugs and combine it with transplantation, the real problem is bring the patient to transplantation, and there is certainly, brentuximab can be helpful. The other question, of course, is that half of the patients, when they received an autologous transplantation, they still relapse, especially the ones who are relapsing early after first-line therapy. And therefore, there was a study recently published in the Lancet. Sorry, that was one too much. That was a study when patients who were considered high risk, this is the definition here, so it was patients refractory to frontline therapy, patients with an early relapse, and patients with a later relapse but extranodal disease. These patients, they were given salvage chemotherapy, they had an autologous transplant, and then they either received placebo or brentuximab vedotin. And that here, in short, shows you the progression-free survival for the two arms of the study, or the patients on the two arms of the study. This here, the upper curve are the patients who had the brentuximab vedotin, and these are the patients who were just observed. There was, as you see, the hazard ratio was 0.5, so that was significant. Unfortunately for the patient and also for the company selling the drug, the overall survival was not significant, and therefore there was no license so far in Europe for using brentuximab vedotin as maintenance treatment or consolidation after autologous transplantation. But as you can see, obviously for some patients you can improve the situation. That's all for the time being on Hodgkin's disease. I think what I can add perhaps is, talking about PD-1 and PD-1 ligand antibodies. Of course, there are already very small studies looking at patients with relapsed Hodgkin's disease, and the question, what happens if you give it after or before autologous and or allogeneic transplantation? The picture is not very clear. What I think is clear, that it seems to be you have to be very careful with it. These immunomodifiers, as you call them, of course they have effects, deep effects on the immune recovery system, and if you then give an allogeneic transplantation, the situation can be a little bit of a problem. So I'm coming now to diffuse large B-cell lymphoma. Again, as you can see here, there is still, a number of autologous but also allogeneic transplants being done in Europe and other parts of this world for diffuse large B-cell lymphoma. One question, of course, is giving an autologous transplant, at least to high-risk patients with diffuse large B-cell lymphoma, is it worth doing it? That was a study which we published a couple of years ago. This here was the so-called standard arm. It was just the CHOP regimen. We gave also etoposide, therefore it's called CHOEP. And that, the upper arm, the experimental arm of that study was giving repeated sequential high-dose therapy, so very high doses of cyclophosphamide. We increased also the etoposide and the doxorubicin. And, you may be disappointed or not. These are the results. This is the event-free survival and the overall survival. And the upper curve in red here is not the transplant curve, or doesn't represent the transplant patients, but represents, the patients who had the conventional chemotherapy. So out of that study, our conclusion was that you would not use anymore in the era of R-CHOP. So there were some studies in the CHOP era. If you add Rituxan, then you don't need an autologous transplant. I should mention to you that overall there have been 4 studies in a very similar setting. The only one which so far has been fully published, except for ours, is the one by Pat Stiff from the US that was published in the New England Journal. Nevertheless, I believe this study is heavily flawed, and I think the results they are showing are certainly not reflecting what we would be doing. It starts that, some of the patients here had only CHOP21, not Rituxan. There were some patients also given Rituxan, but I don't believe that this study is reflecting the practice, what you would be doing with your patient in 2016. All of the other studies, especially this one here, was showing directing in the same direction. And Umberto Vitolo, we have been discussing it very much. He saw, as you can see, a little difference in progression-free survival in favor of high-dose therapy. Looking at the overall survival, you see there is no difference. And the Italians have also given up to do transplants as part of first-line therapy. What about relapsed? What about relapsed and refractory diffuse large B-cell lymphoma? I think the pivotal study to answer that question was the one where the PI was Christian Gisselbrecht from Paris. It was a study where patients were randomized to receive either R-ICE or R-DHAP, and the ones who achieved a PR or a CR then had again beam and autologous transplantation. There was also a second randomization. Patients received Rituxan maintenance versus observation. There was no difference at all between these patients here, so I think I'm not going to talk about this. There was also no difference between the 2 salvage regimens, telling you use the regimen you want. There is also another study I'm not showing to you by the Canadians showing that gemcitabine containing regimen also serves well to the point. So I think the jury is still out. What is the best salvage regimen for patients with diffuse large B-cell lymphoma? The more important or the most important thing, what I believe came out of this study is that if you look at this curve here, this is a curve representing patients who had R-CHOP first line and who had an early relapse, so within the first 12 months. This is, most of the patients, it's the majority of patients we are dealing with today. And unfortunately, the truth is that these patients, they are really not doing very well with autologous transplantation. There is another study by the Dutch, which basically shows the same results with another antibody. So let's say you can do autologous transplants, you can do it in the ones with a late relapse, but you probably should not do it anymore in patients who have an early relapse. So that is at least what we are doing. We have, something like 2 years ago now, or 1.5 years ago, we published the results with allogeneic transplantation in that setting. It was a prospective study looking at allogeneic transplantation in patients mostly with diffuse large B-cell lymphoma. There were also a few T-cell lymphomas in it, and this is the overall and the progression-free survival of these patients. And I think at least, of course, that it's not a comparison because these patients, they were very, very far advanced disease. 90% of them had received an autologous transplant before they went to allogeneic transplantation. Still, the results look much better than with allogeneic autologous transplantation. So having looked at this data and looked at the auto data, this is something we are still considering. The study has not taken off so far because of regulatory issues we have in Germany to bring patient to launch studies with transplantation. I think for the sake of time, I'm not going into details here. In the end, this is a very complicated study, which in the end brings some patients to autologous transplantation and other patients who are very high risk or high risk. These patients receive an allogeneic transplant. What about the new drugs? Another list of new drugs, of course a little bit different from patients with Hodgkin's disease, although brentuximab vedotin, it is also now used in other lymphomas which are not regularly strongly CD30 positive. You can certainly also use PD-1 antibodies or PD-1 ligand antibodies. We will be in the German high-grade lymphoma study group, starting with the French and others, a group in elderly patients not eligible for transplantation very shortly. So there is not much data on brentuximab, and there is not much data on PD-1 or PD-1 ligand antibodies. This list here, shows, some substances interfering with B-cell receptor signaling. For instance, ancestaurin. We participated in a study which is now in press in the JCO. No effect of ancestaurin at all when you use it as maintenance treatment. There are some data on ibrutinib in this disease category. We hopefully this year will start a study which in young high-risk patients will use ibrutinib plus R-CHOEP, so what we have been done before. There is certainly no data. There is a big international study looking at ibrutinib plus R-CHOP. The data are not available. You have BCL6, BCL2 inhibitors. BCL2 inhibitors in diffuse large B-cell lymphoma don't work very well, so I think nobody is at this time actively pursuing such a study. The proteasome inhibitors, there was a study being published last ASH, which was quite negative. So, the only one perhaps you might want to discuss is lenalidomide. There is a phase 3 study ongoing, adding lenalidomide to R-CHOP. So far you have phase 2 data. Some people believe the data are promising, especially in ABC lymphoma. I think the data are not interpretable because it's just phase 2 studies. It's very few patients. You have patients with all IPIs and so on. So I'm confused, and I would not be able to tell you if lenalidomide really adds something when you talk about the efficacy. T-cell lymphoma. T-cell lymphoma is very rare. Only 10% of all the lymphomas we are seeing in Europe. In some areas of the world, of course, it's much more. You can see there is a lot of activity in T-cell lymphoma. When you talk of transplantation, you see there is a rise in autologous, but there is also a steep rise in allogeneic transplants. Why is that? Well, it is, of course, because the results of conventional treatment are very bad. So let's say what you're usually doing when you see first time a patient with a peripheral T-cell lymphoma, then you give him either CHOP or CHOP plus etoposide. You can, let's say, and that has become something like a standard. Many institutions now add high-dose therapy followed by an autologous transplant as part of first-line therapy. I will be coming back to that because I think it is very, very instrumental to look at what has been happening in this kind of lymphoma and, let's say, what advantages transplantation has, but also what kind of pitfalls you are seeing when you look at this kind of study. So, first of all, autologous transplantation for consolidation. I think you have to realize one important thing. There is no randomized study, so nobody has looked at the question, if you have a peripheral T-cell lymphoma, NOS for instance, and if you get 6 courses of CHOP or CHOP plus etoposide, and then you have a transplant, if this is better than doing nothing. I'm mentioning this to you because what you have to see, and I will give you some examples, reaching a time and a stage that you have had 6 courses of CHOP is already positive selection, because 1/3 of the patients don't make it to this kind of end of chemotherapy, And therefore, I think the question is well taken to look if these patients really need a transplant. I'm recently becoming more and more conservative, and I can tell you I have now, only a handful of patients, but I have them who made it very well through chemotherapy. I didn't do a transplant, and nobody of them so far has relapsed. So it is a question. It is really a question if the standard of care, as some of the guidelines are giving you, if this is really standard of care. These are at least we have some prospective studies. These are the prospective studies we have. The largest one is the one by Francesco D'Amore from the Nordic Lymphoma Group, because this is the largest and it had the longest follow-up. I show you a little bit how it went. So the Nordic countries, they believe in CHOP plus etoposide for the T-cell lymphomas. So as you see, these patients here, they are receiving overall 6 courses of CHOEP 14, and the ones being in CR/PR, they received high-dose chemotherapy, the beam regimen, autologous stem cells, and then were followed. And these here are, the major results. I think it is enough to look at this here. This is, the overall survival, the progression-free survival, and I would say, approximately half of the patients, they are put in remission long-term. If you want to look what the real question is, then I think, this study, which was published, I think in 2014 by Paolo Corradini from Milano, this is very instrumental, and it's very interesting to see. Again, I'm not taking you through all of the details of the study. The idea was to do allogeneic transplantation first line, and only the ones who didn't find a donor, they would go for an auto transplant. I think the important information is only 61% of the patients who started here with CHOP alemtuzumab, only 61% were able to receive either the allo or the auto transplant. 40% of the patients didn't make it. We did a similar study. That was a really randomized study, so we upfront randomized the patient. That was a study done together with the French LUSA group. We did a study where we gave the patients, after randomization, 4 courses of CHOEP, and the CR/PR patients, they went on to receive DHAP. The ones scheduled for an autologous transplant had a peripheral blood stem cell harvest, then beam and autologous transplantation. The ones randomized to allogeneic transplantation, if they had found a donor, they received a myeloablative regimen, FBC, followed by stem cells, or allogeneic stem cells. And of course, the ones who did not find a donor, they then had a peripheral blood stem cell harvest and could have a high-dose therapy and autologous transplantation. Again, I'm not going into details of the study. This is the overall survival. At the time of the interim analysis, where only 58 patients were on study. We closed the study after 104 patients. I have no data on that. At the time of the interim analysis, as you can see, there was no significant difference between the arms. The allo arm tended to be a little bit lower, but of course, we are following all the patients very closely, and what we are continuing to see is that in the auto arm, more and more patients are relapsing, while if you are lucky enough to receive an allo to survive the acute transplant-related problems, then there is a strong graft versus lymphoma effect, and we have so far not seen a single patient relapsing after a successful allogeneic transplantation. So it will be very interesting when next year, hopefully, we will be doing the final analysis of the patients, if the curves are holding like this, or if they will merge, or finally the allo arm will be even better. So far, I think the lesson to be learned from this study also is 40% of the patients don't make it to transplant. If you are considering allogeneic transplantation outside of a study, I cannot recommend it to you in 2016. What about relapsed T-cell lymphoma, refractory T-cell lymphoma? Well, the first message, I think, again, no comparative studies. The other message is the outlook for a patient who has a relapsed T-cell lymphoma is really very, very bad. These are patients who did not receive an auto or an allo transplant. This is, from British Columbia. And as you can see, the curves are very, very narrow, or they touch, the abscissa. So these patients are really, really destined to die when you relapse with the T-cell lymphoma. What can you achieve with transplantation? These are some autologous transplant results. Actually, it is EBMT results. It was a large cohort, something like 450 patients. We have never published it, because we really had difficulties to look at the histology reports. And of course, you will never be able to publish it in a decent journal when you don't have it. So these are the results. However, of course, I have to tell you, these results are heavily biased, but because it only represents patients who made it to transplantation, and it does not tell you anything about all of the patients who had been relapsed and might be candidates for an autologous transplant. Sorry, I think there is one missing here. Yeah, sorry. I think there is a mistake here because I wanted, of course, to talk a little bit about allogeneic transplantation. I think the results of allogeneic transplantation in the relapsed refractory setting are quite solid. 50% of the patients receiving an allogeneic transplantation, they achieve long-term remissions, and some of them, after 5, 6, 7, 10 years, you can say they might be cured. So allogeneic transplantation, if the patient is making it to transplantation, I think for a relapsed patient is the modality to go for. In the remaining minutes I have, just a little glimpse on some of the other major lymphomas. This is mantle cell lymphoma. You see, increasing activity, especially, in the autologous setting. Why is this so? I think, all of that, in a way, is based on that study. Of course, there have been other contributors, but, Christian Geisler, he was the one who in 2008, for the first time, published, this study here, and this is, from an update in 2012. And let's say what really changed the view on mantle cell lymphoma was 3 things. Giving Ara-C instead of CHOP. Here it is CHOP Ara-C, in turn. But now many people say, okay, CHOP is not very good. For mantle cell lymphoma, just give the patient Ara-C. It is the Rituxan, as it is, shown here, and it is the autologous transplant. These 3 things, whatever you do, this is in a way the backbone for now successfully treating a mantle cell lymphoma. After this publication, there have been other activities to further improve the results, with not very much success, I must say, but the results for this year are quite good. This is just another study which Olivier Hermine from Paris published recently in The Lancet. As you see, that was then a randomized study. The previous one, of course, was a phase 2 study, not randomized. That was a randomized study. The patients received R-CHOP, or they received R-CHOP and R-DHAP alternating, and the patients in that arm of the study were doing significantly better than the ones who received the traditional R-CHOP and then went on to cyclophosphamide TBI and autologous transplantation. We have been talking about MRD a lot, in other diseases, especially multiple myeloma. MRD measurement is also important in mantle cell lymphoma and in other lymphomas. Of course, the question also in lymphoma is, what are you doing when you have a patient becoming MRD positive again? I think, again, the people, from Scandinavia, from the Nordic Lymphoma Group, they did something they call preemptive Rituxan. And what they showed is if you have a patient who is only MRD positive, has no clinical relapse, you can bring the patient back to MRD negative by infusing Rituxan. So that is a policy many of us now around the world are following. This is, from the ARMIN trial, the comparison, DHAP versus CHOP. You see there is, if you look at time to treatment failure, there is a clear evidence of superiority of the patients who had R-DHAP as opposed to the patients who had R-CHOP. This is a study, which is an Italian study, which is looking at maintenance therapy with lenalidomide in mantle cell lymphoma. No results available. This is, what now is being done in the European Mantle Cell Lymphoma Network. As you can see, ibrutinib, the I is ibrutinib here, is being added to the conventional chemotherapy, and it is also added to DHAP, and it is also in one of the arms is given after autologous stem cell transplantation. Of course, no data available. We will see, what is the best arm. I think I have shown that to you. I skipped that for the sake of time. Follicular lymphoma is the last entity. I would say a few words about it. Follicular lymphoma, as you can see, autologous transplantation and allogeneic transplantation, the numbers are quite similar over recent years, so there is not this much of an increase as compared, for instance, for T-cell lymphoma. Why is that the case? Well, of course, in follicular lymphoma, you have an abundance of new drugs, and the new drugs, in contrast to diffuse large B-cell lymphoma, for instance, they work. So if you have a follicular lymphoma, you can give the patient idelalisib, you can give the patient ibrutinib, you have other drugs. So, and then, of course, you have all of the combinations available. It is very, very rare now that a patient is ending up at a question or at a time when you say, is there nothing else? Do we have to do a transplant? What, in the German study group now is being done, that is the only activity talking about transplantation. They want to do a study to compare autologous transplantation versus radioimmunotherapy in the relapse setting. That study also is on hold because of regulatory issues in Germany. It is really a pity. These agencies are making you really, they are making you crazy. But that's how it is. So that study is planned. It's not running. There is no other activity. Talking about first-line therapy, I think in the era of Rituxan and also lenalidomide and other drugs, there is certainly no role for autologous transplantation as part of first-line therapy. In the relapse setting, I think there are some patients who might benefit from it. I think the real problem, and I think I stop here for the sake of time, the real problem is now, you have so many drugs, you have so many possible combinations. Nobody knows, and we will not be able to do all the studies we ought to do to find out, for instance, in follicular lymphoma, what is the best chemotherapy. And we want to integrate transplantation, autologous or allogeneic transplantation, into the course of treatment. And I think that is, a really hard question to answer. When we are talking to our statisticians, for instance, there is no hope that we will be able, to look at all of the drugs and compare them and find out what really is the best drug. So the jury is still out. How are we approaching this problem? I think, of course, the situation is very good that you have so many options. We can treat the patients even in third and fourth and fifth relapse. Scientifically, it is a little bit of a problem, but I think the message in the end is in 2016, and I don't see it also, let's say, for the next 5 years, patients with at least relapse and refractory lymphoma, they won't be cured and they won't achieve long-term remission without autologous, and in some situations allogeneic transplantation. I stop here and thank you very much for your attention.
Thank you, Professor Schmitz, for this extremely interesting and extremely, for me, also astonishing field. I would also start the discussion with one question from me. We all have problems with the treatment of patients with T-cell lymphoma. And if the patient is not developing good, we have a problem what to do. You mentioned the role of allogeneic stem cell transplantation. Which induction stadium would you, which remission status would you accept before the allogeneic transplantation? Is partial remission enough?
We accept any remission status. Really, we have some data on it. With allogeneic transplantation in T-cell lymphoma, you can, of course, transplant CR, PR, stable disease patients, and you can also successfully transplant those patients who have, let's say, a stable disease and a little bit activity. For instance, we have done 10, 20, maybe even more patients where the LDH was rising again. They had some lumps and they were PET positive. Of course, if you have a patient, with lymph nodes like that, it will be a problem. I'm not advertising do a transplant in any T-cell lymphoma, whatever the situation is, but the GVL effect in T-cell lymphoma is this strong that you can accept patients who are progressing. And the problem, as I say, is if you have one of these patients who after the second or the third course of CHOP or CHOEP is then again telling you I have B symptoms, the lymph nodes are growing, you don't have a lot of alternatives, So I haven't had the time to talk about it. All of the new drugs, in T-cell lymphoma, you have licensed pralatrexate, you have brentuximab, you have a couple of other drugs licensed. None of it works, in this kind of setting. Or it works, for a very limited period of time, and the patients start progressing again. So there is no alternative, and then, up to an age of 70, 75, do a transplant. You are not going to lose anything, Otherwise, I think I showed you the curves for the one not making a transplant. Unfortunately, the patient is destined to die.
Thank you.
Thank you very much. It has been really very, very interesting. But small cell lymphoma or CLL and allogeneic transplantation, what is your suggestions, please?
Well, that's another field. We have. I personally, have not been actively, following it because Peter Dreger, who is now in Heidelberg, he is the one, who is talking about it all the time. And we have been working together, I think, more than a decade. So, of course, in the era of new drugs, ibrutinib, idelalisib, whatever, it is very, very challenging to, ask the question. I think in CLL, autologous transplantation is not a question anymore. We did a study. Let's say it delayed the relapse a little bit, but in the end, it didn't save the life of anybody. Allogeneic transplantation, I think the consensus at this time is that, of course, you should start, first-line therapy. If the patient is 17p deleted, there is not many drugs which are working. You know that the new molecules, many people say, okay, these patients with 17p deletion, they also benefit from the new drugs. I think you can do it. Some of the patients will relapse, and then again, there is nothing else than allogeneic transplantation. I think doing it first line in high-risk patients, this is something in 2016 you would not do anymore.
Thank you. Professor Holowiecki.
Concerning diffuse large B-cell, they go mostly quite fine.
Yeah.
But except it's probably for those cases that start with no testicular or brain or mediastinally infiltrate. Do you confirm this opinion?
Well, of course, let's say the worst. Sure. Let's say the worst is, of course, the patients, with CNS disease. The ones who have simultaneously, primary CNS lymphoma is a different disease, but also the ones who have diffuse large B-cell lymphoma simultaneously in the lymph node and in the brain, they are doing very, very badly. It is still not clear what is the best regimen. What is currently being done is you give them high-dose methotrexate, you give them high-dose RSC, and of course, the ones who are achieving a remission, all of them are going to transplant. Like the primary CNS lymphomas who have a transplant, also the ones with secondary CNS involvement or simultaneous CNS lymph node involvement. We are doing autologous transplant on these patients. Of course, what we do is you give them high-dose therapy with drugs crossing the blood-brain barrier. And that, of course, is very interesting because ibrutinib is crossing the blood-brain barrier. And we have some preliminary data, and it has also been, I think there have been 3 or 4 cases being published in Blood, for instance, patients on ibrutinib and also some on lenalidomide monotherapy, they achieve a complete remission with these drugs. So we are integrating these drugs now into the regimens. Of course, no data available, but hopefully now the situation will improve a little bit.
And question concerning Hodgkin.
Yeah.
Do you see any advantage of making thymidine scan instead of
which scan?
Thymidine in PET. CT.
Yeah, I have, I have no experience. The PET scans in Germany for a long, long time, as you may know, they were very restricted, so we didn't have the possibility gaining broad experience. In the studies of the German Hodgkin's disease study group, it is very clear that the positive predictive value and especially the negative predictive value of PET scanning, normal PET scanning, is good. So whenever you have the chance, do it. And if a patient at the end of treatment is PET positive, it's not a good sign.
Thank
you. Dear Professor, a very short question. How do you think about nelarabine? Nelarabine.
I have in lymphoma in general, or I have no experience, and I think the data are very, very limited, so I can't answer the question.
I have purely a philosophical probably question, but so we live in very restrictive society in a way that, the patient comes to the doctor and now you have lymphoma or whatever, you say, well, we give you rituximab, we could do allogeneic transplantation, you will get PET scan, whatever. That costs a lot of money for the society, right? And if you would offer people cash, let's say 150,000, for that, whether you go for the treatment or you do whatever you want with that, what do you think? How many people would go for the cash instead of going for the treatment?
Well, let's say that is really a philosophical question, of course. Let's say in the end, the question is, how much money are you going to spend per day of life? I must say that in many of the solid tumors, this question, of course, applies much, much more, because when you see in breast cancer and in lung cancer, for instance, you see studies with drugs, and then, you have 3,000 patients on study, and then there is a significant difference, in favor of patients who receive drug X. You can, of course, ask this question. This is, of course, for the society a very heavy load, because these diseases are much more frequent, and the benefit is very, very limited. I would say in the lymphomas in general, you can cure them. If you talk about Hodgkin, or if you talk about diffuse large B-cell lymphoma or follicular lymphoma, giving ABVD costs almost nothing. giving R-CHOP. Okay, the Rituxan is not for free. There will be biosimilars. The shop is very cheap, so I think that is probably, any society might be able to afford. When it then comes to transplantation, when it comes to the new drugs, of course, you have to make, in a way, you have to discuss it. And as, one of the former presidents of EBMT told me, of course you want your children educated, you want your streets being fixed, and the question is, as money is not endless, what to do. But I really think this is not a question we as physicians can solve. Let's say, for me, being a physician, the target must be to save the lives of as many patients as possible. And if somebody tells me this drug you are not allowed to use, and if the society has decided it's like this, I have to accept it, of course. But I'm not making my own rules. That's, I think, the important thing. This needs to be overseen, surveyed by other people, and I think it is not a decision of physicians.
The time is progressing.
Oh, I'm well aware of the fact, and of course, let's say there is a lot of people who obviously have the money. If you can't get it in your country, go to another country. That's how it is. You find it good or you don't find it good. That's how it is. Again, I don't feel in a position to be the judge and say, you get it or you don't get it. I'm just a physician, and if I have the possibility to give the patient CAR T cells, for instance, which may cost 400,000 euros, then I give him CAR T cells. If somebody tells me, for this patient, we don't pay for it, we don't pay for it. I can't change it. That's how it is.
We are very progressive at the time. I think there is a possibility for only one more question.
I would like to ask, here's the question. Could you comment a little bit more about the role of stem cell transplantation following this immune modulating agents, PD-1, BDL1 inhibitors?
What would you like to know?
Because you mentioned that one should be cautious during this transplant. Well, so what's the secret?
Let's say the results for Hodgkin's disease, for instance, have been published. There are preliminary data, for other lymphomas. In Hodgkin's disease, I think that is very clear. In Hodgkin's disease, the data are particularly good. If you look at diffuse large B-cell lymphoma, if you look at T-cell lymphoma, the data are very limited and they don't seem as good. So I certainly do not believe that PD-1 antibodies or PD-1 ligand antibodies will solve the question. And by the way, also CAR T cells. Let's say the CAR T cell hype, as I call it, is forgetting one thing. At this time, and you talk to everybody who is involved in doing it, 50% of the patients you are unable to harvest and to expand the CAR T cells. So 50% of the patients have no chance to receive them. And if you do an intent to treat analysis, then giving CAR T cells, for instance, to patients with diffuse large B-cell lymphoma, then your overall response rate is 25%. 25%. That is, less than Rituxan when it was given as monotherapy in the pre-Rituxan era. So I'm not saying CAR T cells are not working because it's a new technology. We can certainly improve it. It's a great idea. We should do it. But you have always to be realistic. And at this time, number one, they are not available. Number two, it is heavily overestimated what they can do in different diseases. That's what I think and what the data tell me.
Thank
and
you.
It's also with the new drugs.
Thank you very much, Professor Schmitz. Thank you very much, audience, for the nice discussion. I would give the microphone to Professor Lajnice.
Thank you, lecturers and participants, and we have coffee break at the moment, and we will be back after 15 minutes.